Good morning and good afternoon. I'm Victor Zhao, the President of the National Academy of Medicine. It's my distinct pleasure to welcome all of you to the 51st National Academy of Medicine annual meeting. Thank you for spending your Sunday afternoon or morning in the West Coast with us. For members of the public who are joining us for the first time and may not be familiar with the National Academies, let me tell you a little bit about who we are. We were chartered by Congress and President Abraham Lincoln in 1863 as an independent advisor to the nation on matters of science, technology, and health. Over the years, we've gained a reputation of providing independent, science-based, and trusted advice impacting the nation and the world. The National Academy of Medicine have distinguished members who are at the forefront of discovery and progress in health medicine and the biomedical sciences. Held every October, the NAM annual meeting is the gathering of our distinguished members and the most important meeting of the year for the organization. Now, COVID has created immense challenges for all of us over the past 20 months, but it's also offered opportunities to innovate and adapt. So last year, for the first time, we decided to conduct the meeting entirely virtually and open our interest group meetings to the public. This approach was really quite successful. We decided to continue it this year. Now, the interest groups bring together NAM members from a variety of disciplines and sections to enrich the understanding and to engage in dynamic conversation on pertinent scientific and policy topics. You know, the program is driven totally by the NAM members. All interest groups meet during the annual meeting. They may develop new ideas for program activities or other initiatives by the NAM and assist membership sections in the discovery of outstanding candidates for membership, especially younger individuals working in interdisciplinary or emerging fields. In fact, I've been so impressed with the enthusiasm and engagement of members in the interest groups and the quality of interest group programs that I'm thinking of making the interest group program as part of the official scientific program every year in the future. So please stay tuned. So I hope you join the scientific program tomorrow. We have an outstanding program in store for all of you. The theme of this year's program is Crossing the Policy and Equity Chasm, Lessons Learned from Compounding Health Crisis. And it will focus on the importance of science-informed policy to address the existential, persistent health threats and inequities of COVID-19 and climate change. It's going to be a great event with the keynote opening from Dr. Eric Lander, President Biden's science advisor, Director of the White House Office of Science, Technology, and Policy, and a member of the President's Cabinet. In addition, there will be a number of distinguished speakers and leaders. Towards the end of the scientific meeting, the Secretary of Health and Human Services, Javier Becerra, will deliver a closing keynote. After the scientific meeting, I'll chair the President's Forum, which will formally discuss the NAM's Grand Challenge on health, human health, and climate change. The forum will kick off with an opening keynote address from Gina McCarthy, the White House National Climate Advisor. The scientific meeting will begin promptly at 10 a.m. Eastern Daylight Savings Time, and I hope I'll see you all there. And now over to the interest group session. Thank you.
Well, hello, everyone, and welcome to the Primary Care Special Interest Group meeting of the National Academy of Medicine. And this particular session focused on strengthening primary care as a solution to current and to future healthcare priorities. We're really delighted that you're here joining us. I'm Mary Wakefield, and I am a member of the National Academy. And along with the terrific Dr. Andrew Bazemore, we're co-chairing the planning committee that is bringing to you this particular session. Before we get into the content of today's meeting, though, I want to thank just a few people who helped us to get to this point. First, Jamal Samuel with the National Academy of Medicine, who's been terrific in providing his assistance in facilitating the session. And secondly, I also want to mention the planning committee colleagues who volunteered to serve and work with us to put today's program together. And those individuals include Drs. Kara Walker, Harold Sachs, Jim Perrin, Bob Phillips, and Andrew Bazemore. With that, in terms of a few specific logistics I need to share with you. First point is that the introductions of our speakers that you're going to hear today, those introductions are going to be really brief. And the reason why we're doing that is because we want to spend as much time as possible on discussing content. So brief introductions, not at all a reflection of a tremendous set of players and panelists who have a long list of professional achievements. However, if you do want more information about these individuals, you can find that information in the chat room where their bios are available by clicking on the link that's provided for you there. Next, for you to know, this meeting is, as was mentioned by Dr. Zhao, open to both National Academy of Medicine members as well as non-members from now through the panel discussion. For our public registrants, our non-National Academy of members, you're going to be viewing this meeting as a webinar. And so you will not have real-time access to submit any chat comments or participate via audio. However, the Academy does want to hear from you, and our special interest group certainly wants to hear from you. So to the extent that you've got any observations or questions, please don't hesitate to make them available to us at the email address listed on our viewing webpage. After the meeting, those questions would be sent to any panelists that you may have directed them to. Then, for the members of the Academy, please do feel free to use the Zoom function, the chat function, at any point in time during today's session. Also, if you wish, you may want to use the raised hand function after all of the panelists have spoken and we get into a discussion. That will also be an opportunity to engage as well. So either via the chat session or chat function or via hands raised. And we'll try to catch those questions as we go along. Well, with that, let's go ahead and turn our attention to today's topic, a conversation that in a very exciting way is going to pivot right off of the National Academy of Medicine report that was released earlier this year, titled Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. Well, this report explores the challenges around primary care in the United States and the impact of those challenges on health and healthcare. The report also very quickly moves to advancing important features of an implementation plan for rebuilding primary care as a core foundation to health. To talk about the report and to provide us with an overview of some of its key messages and observations, with us today is Dr. Bob Phillips, who is an expert on the report, and he's an expert for a lot of reasons, not the least of which is he was a co-chair of the National Academy of Medicine that produced the report. And I also want to mention his co-chair, Dr. Linda McCauley, who co-led the committee with him. She is also a National Academy of member and a nurse. Following Dr. Phillips' remarks, Dr. Bazemore will introduce the panelists to you. The panelists are going to weigh in on some of the key actions that are recommended in the report, all with an aim of strengthening primary care in service to the health of the nation. So that quick word about Dr. Phillips and then straight over to him. Dr. Phillips trained in family medicine, and he is currently the founding executive director at the Center for Professionalism and Value in Healthcare. That's part of the American Board of Family Medicine Foundation. With that, Bob, over to you, and thanks for being here.
Harry, thanks so much for that kind introduction, and thank you to you and Andrew for organizing today's topic. As Dr. Wakefield said, I'm going to be talking about the report and giving you some highlights. One of the things I want to emphasize, and I think that we'll be emphasizing throughout the discussions today, is this issue about implementation, how we actually make sure that the recommendations reach fruition and have champions. As Mary said, Linda McCauley, the Dean of Nursing at Emory University, was co-chair with me, and many of our colleagues who helped prepare the report are on the panel today. So I'm grateful for their help, and also for the 3 National Academy of Medicine Fellows and our staff, and Mark Meisner and Cheryl Nass and Tracy Lustig and Sarah Robinson and Samira Abbas, who were essential to making sure that the report came to fruition. We did have 17 sponsors. That's a lot. It gave us a lot of upfront feedback about what was expected of the report. The good news is, on the back end, it's given us a lot of champions, many of whom continue to advocate for a lot of the recommendations in the report, and we're very grateful to them. Our statement of task is a little unusual. We were not only challenged to talk about how to build on the 1996 IOM report about primary care and focusing on strengthening primary care and informing primary care systems around the world, but we were given this task of developing an implementation plan, which is very unusual for National Academies consensus studies. So we have a very strong focus in the report on how to follow through on the recommendations and who could be accountable. As in 1996, our committee started with developing a definition. And sorry, this slide is really focusing too on that implementation plan and considering the successes and limitations of the prior efforts to innovate in primary care. So our statement, our definition around implementation was quite specific, and we made sure that the committee understood this as the definition of what we were trying to achieve. As I started to say, we also had a challenge of coming together around a definition for primary care, which I'll talk about in just a moment. In terms of context, some of the key things that came out of the review of the literature, the first and kind of primary one was that primary care remains the only part of the healthcare system that results in longer lives and more equity, emphasizing its importance and why fixing it becomes such a high priority. And we can point to other countries that have high quality primary care and better health outcomes as a result, and that primary care is inaccessible for large portions of the US population, and that we're actually seeing a regression, a loss of primary care use and utilization, and we're seeing an erosion of the workforce. One of the explanations is that primary care is now only about 5% of total healthcare spend. It remains more than 1/3 of all visits, more than half of all outpatient visits, but receives only 1/3 of funding that goes into subspecialty care and 1/5 of what goes into hospital-based care. So one of the things I want to emphasize is this has actually declined over the last 15 years. So as a function of the health system and as a funding target of the health system, it has declined. So it is under-resourced, and its share of total healthcare spending is decreasing in most states. This underinvestment really leads to health inequity and financial pressures on practices. It results in clinician burnout and really suboptimal care, and is part of the explanation for why we're seeing a loss of life expectancy gains compared to the last 100 years. Primary care as a function is weakening in the United States when it's needed most, and fundamentally lacks a unified voice within health and human services. Of course, COVID-19 and the pandemic really amplified the economic, mental health, and social inequities that are happening in the country. If you listened to the interest group panels in the last session, this came out very clearly. It's created problems with access to care. It's created financial pressures on practices that are driving some to close and others to be absorbed into larger health systems. Primary care is where the majority of adult and children vaccines have been given for many decades. It was true before the pandemic, and yet it was not considered as part of the vaccine distribution plan until recently. There have been some meaningful policy changes like relaxation of telehealth rules, but it remains to be seen if some of those will stay in play. So back to the definition, we thought this was essential for the committee to make sure that it started on the same page in what we were talking about. And it is slightly different than the 1996 definition. So it is that high quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare delivered by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. And two of the important changes here was the focus on interprofessional teams because that's how we get to more robust, comprehensive care delivered in primary care settings. But we recognize we shouldn't neglect relationship, which is at the heart of the therapeutic benefit of primary care, but that relationship isn't just with the patient. It really means refocusing on their families and their communities as well. So the second kind of high level focus that came out of the committee is that primary care should be a common good. Everyone should have access to it that wants to have access to it. It has such high societal value, yet it's in a precarious state. And that without some specific public policy and accountability mechanisms, that it's unlikely to happen. And so we've also turned to colleagues on the committee and off the committee, trying to create some pressure for advocacy and organized leadership, particularly at the federal level. But we didn't stop there. When we certainly looked at government in terms of implementation, but we also looked at what needs to change within health systems, what needs to change in practices, and recognizing that we need an accountability system. That means creating some champions within the federal government who have oversight of primary care broadly, and creating some accountability tracking tools like public scorecards. And we've worked very hard, both during the committee's work and after, to align the recommendations with the priorities of the administration and the priorities coming out of the pandemic. And we really boiled this down to 5 very specific objectives. The first is around payment, second around access, third around workforce, and the fourth around digital health, with this wrap around 5th objective called accountability that we'll talk about more. And so the first is really paying for primary care teams to care for people, not doctors, to deliver services, and I'll explain that in a moment. The second really deals with our objective of making primary care a common good by ensuring that high quality primary care is available to every individual and family in every community. The third is around making sure that we train primary care teams where people live and work and not just in academic health centers. And the fourth is around making sure that our digital platforms really work to serve patients and families and interprofessional teams. And the fifth, as I mentioned, is about implementation and accountability. To get really specific, we talked about payers being able to evaluate and disseminate payments based on their ability to promote delivery of high quality primary care, not to reduce overall costs. You know, our primary function should be making sure that people get the care they need when they need it, and cost should be a secondary issue, and we should recognize it's a long-term function, if at all. And that we should really move from fee-for-service models towards hybrid reimbursement models with increasing turning to population-based payments so that we can make sure that the kinds of care are available to people that we need them to have. Now, if I put a little red asterisk next to an action, it means that we may not have identified a champion for that yet. So in this case, it's around the Centers for Medicare and Medicaid Services, increasing the overall portion of primary care spending by improving the Medicare fee schedule and restoring the Relative Update Committee to an advisory nature. So really taking the lead among payers and shifting more payment towards primary care, specifically to help secure the workforce and to make sure that we can put more robust teams in place. And that we should really, at the state level, focus on multi-payer collaborations, because we know most practices work off of 7 or 8 or 9 different payers, and if only one makes a change, then the practice can't really make a change. Objective 2 around access is making sure that payers ask all beneficiaries to declare usual sources of care. Say who you go to when you need help and when you need health care. This can be health centers, it can be hospitals and primary care, but making sure that each of those are assuming an ongoing relationship for the uninsured that they treat in particular. And action 2 is around HHS really building out more of our critical access points in health centers and rural health clinics and Indian health service facilities in shortage areas. And there's been a lot of resources pushed towards these services already. Also under objective 2 is that CMS should revise access standards for primary care for Medicaid beneficiaries and provide resources to state Medicaid agencies for these changes, really getting to payment parity and making sure that there aren't payment barriers for people on Medicaid to get into care. The fourth under this is that CMS should permanently support COVID-era rule revisions, many of which liberated telehealth and helped practices immensely. And the fifth is that primary care practices should include community members in governance, design, and delivery, much like federally qualified health centers do, so that we can really create partnerships in the communities and with community-based organizations. 3 is around training, and you'll notice that both of the recommendations here have asterisks. We don't have champions yet. And the first one is that healthcare organizations really looking to diversify their workforce and customize teams to meet the needs of the populations they serve, and that government agencies should expand the educational pipelines and improve economic incentives for getting more people to work and train in these teams. The second one is that CMS, the Veterans Health Administration, HRSA, and states, in their funding of training through Title VII and Title VIII and GME funding under Medicare, should really support interprofessional training in community-based primary care practice environments. This is getting back to training and working where people live and work. Objective 4 around digital health really points on the first recommendation that the Office of National Coordinator for Health Information Technology and CMS should develop a next phase of digital health certification standards that support relationship-based, continuous, and person-centered care, the kind of care that primary care should be delivering most broadly, that we should simplify the user experience, then that we should ensure equitable access and use to those health information technologies, and that we should be holding vendors accountable, not the providers, not the clinicians. And the second one is that those two agencies should work together again to adopt a comprehensive aggregate patient data system, because people are getting care all over, and we're not able to, in primary care, coordinate their care very well if we're not able to access those different sources of their health information. And right now, patients can't even give us permission to access those data in a regular way. Under Objective 5, the highest priority, the number 1 recommendation, is that the Secretary of Health and Human Services should establish a Secretary's Council on Primary Care. So this is an interagency work group within HHS that works to coordinate primary care policy across the agencies and making sure that there's adequate budgetary resources for that work, and that it should have a reporting function. And the second part of this is we recommended that it have an advisory committee so that stakeholders can help with identifying priorities and helping get the support that the council needs to move its agenda forward. Also under Objective 5 is the recommendation for formation of an Office of Primary Care Research at the National Institutes of Health. We identified other evidence that suggests that primary care gets less than 1% of all funding for research from federal resources. And we feel that having a footprint on the NIH campus might help that, just like the emergency care, the Center for Emergency Care Research did 15 years ago. And we also call for funding of primary care research at the Agency for Healthcare Research and Quality, much like RAND did the summer before. The National Center for Excellence in Primary Care Research has never been funded by Congress, even though it was established in 1996 by Congress as the place where primary care research should be funded. And the third action under Objective 5 is calling on primary care professional societies and consumer groups and philanthropies to assemble and regularly compile a high-quality primary care implementation scorecard. And the appendix, one of the appendices of the report, lays this out as something that could be done right now using existing data sources to help track some of the things that our recommendations are aiming to achieve. And again, the scorecard measures are items that are already in use. They're not new. They're few in number so that they're easily understood and can be tracked consistently. They're built on data that's regularly collected and publicly available, and they're appropriate for use at national level and at the state level. As a follow-on from the report, for folks wanting to read more, we did publish a viewpoint in JAMA on the same day that the report was released. A few weeks later, with the leadership from Kevin Grumbach, New England Journal of Medicine piece came out really focusing on the implementation plan from the report. And Alex Christ, who was on the committee, led a recent paper in JAMIA on the digital health needs. So there are a number of products coming out of this report that people might find useful for becoming champions for some of the things that we've recommended. And I also wanted to just point to a couple other resources on our website at the National Academies. There are briefs for each of the objectives, including one on implementing high quality primary care. 2-page brief, very easy to enter and easy to use to help talk about the recommendations. We've also had 5 workshops, one on each of the objectives. Many of the folks on our panel and on the webinar were parts of the panels for each of these. And I'd invite you to go to the website because the videos for each of these panels are still available. And on October 25th, we're not finished yet. We will actually have our last workshop hosted by the National Academies. It's a closed door workshop between payers and health systems, trying to understand if payers do shift resources to primary care, how will we know that health systems are using them with that intention, and how will they be accountable? So I will stop there so that we can get to our illustrious panel.
Wow, thanks so much, Bob. That was a wonderful tour de force through a very full report. I do want to make sure I move quickly so we can turn to this remarkable panel. We've asked to respond and really further explore dimensions of the RIFS report and, as importantly, pathways to implementing its recommendations on a national scale. And I think you'll see in the panel why we've asked each of them, and we're really grateful for their attendance on a Sunday. I do want to ask, since I see particularly some of our international members starting to fill the chat, that as the panel speaks, you do the same. Park your questions. We will make sure when we get to the question and answer to address those in the chat, as well as those who manage to speak up and raise their hands. I'll start with a very quick run through these panelists' backgrounds and bios. As Mary has noted, we have put together a complete bio for your perusal, and you'll see we could spend the rest of the session speaking to the panelists. First, Christopher Koller is not only a member of the committee that produced this wonderful report, but the president of the Milbank Memorial Fund. He's going to transition from Bob's overview of the report to really focus on, again, a rationale behind some great news this week and what we might do with a federal Health and Human Services interagency committee or council and interaction. And he's also going to touch on the Milbank Foundation's support and interest in the work that comes after the report. Judith Steinberg, I'm pleased to say, is serving in a truly exciting new role, senior advisory role to the immediate office of the Assistant Secretary for Health. And she can tell you a little bit more about that role and why we think it's exciting and what it means as a part of an initiative to strengthen primary health care in our nation with an aim of improving health outcomes and advancing equity. Stephen Lopez is the counselor to the Secretary of the Health and Human Services, specifically on equity issues. And he will speak to the link between equity, primary care, and also give us reactions to the NAM report, the objectives, and particularly those that are related to an interagency committee. Jim Macrae is the Associate Administrator for the Bureau of Primary Health Care at HRSA. He was going to discuss the Bureau of Primary Health Care's recent efforts to support primary care and really help to outline, connect their consistency with the National Academy's report recommendations. Kameron Matthews is the Assistant Undersecretary for Health for Clinical Services and Chief Medical Officer for the Veterans Health Administration. He's going to touch on the VA's strong and particular interest in related actions in advancing the report's objectives. She's also, and we're grateful to her, one of those who had served on the committee. Pham is the president and the CEO of the Institute for Exceptional Care and has served in many roles that give her authority to discuss primary care financing, both present and in the past. And she's going to point out, again, and reference some relevant points from that recent New England Journal article that Bob mentioned, but specifically talk about primary care financing and the important need for its reform and change to implement the actions or the recommendations of the report. And last, certainly not least, Kevin Grumbach, who is the chair of the Department of Family and Community Medicine and the lead of that New England Journal article, is going to have the opportunity to try to synthesize and add his views based on what he's heard from the panelists and as we look forward. We've agreed in preparation for the meeting with the panelists that they will hand off one to the next in the interest of efficiency and leaving time for discussion and your questions. And with that, I'm going to hand off to Chris Koller.
Thank you very much, Andrew. And thanks also to all of our attendees for showing up. It's my job to talk about particularly the implementation plan that is contained in the committee's recommendations. Before I start, I want to echo Mary's comments and salute the leadership of Bob Phillips and Linda McCauley in leading the committee. It was a privilege to serve with them, and also salute the excellent staff work by Mark Meisner and his team. As Bob noted, we were tasked with an implementation plan. The value of primary care had been asked and answered in comprising the group. That made our work focusing on implementation particularly important. And as Bob said, we start by declaring primary care to be a public good because of its unique contributions to both reducing disparities in health outcomes and increasing lifespan, unique among all health services. It's the job of the government to steward public goods, and we have local, state, and federal government. In our recommendations, we really focused on the role of the federal government because that's ultimately where the buck stops. But in the case of healthcare, all the significant levers, the ability to steward these public goods rest at the federal level, or most of them. That's where policy decisions regarding Medicare, Medicaid, research, and workforce are all made. So you'll see that while we reference a number of stakeholders, we focus on the role of federal government, and I think that will be our conversation today. We recognize that there are lots of public goods and they compete with one another for attention and action by the federal government. We really looked, as we were doing this work and developing our implementation plan, to understand which public goods get attention by the federal government. And so you'll see reference to the policy window, and practically speaking, the notion that public goods must be a priority for both the presidential and the administration, and also for the agencies that are charged with implementing or acting on that public good. And in the case of public goods, there are significantly different parts of federal government that are involved. And so using this language of levers, it's important that the levers be coordinated. That led to this notion of the Secretary's Council. And I will read from, just to underscore what Bob went through. The recommendation regarding the Secretary's Council says that the HHS Secretary should establish a Secretary's Council on primary care to enable, and this is the primary goal, to enable the vision of primary care captured in the committee's definition. It makes recommendations, the details in terms of its members, and it outlines 6 duties relating to payment, workforce, to coordinate the adequacy of research, the adequacy of the research, to look at the technology, the evidence, and the data regarding primary care, to align public and private payers, and to come up with meaningful metrics. More generally, we think that with the significant, again, I'll use that word, levers, that the federal government possesses with regards to primary care, there's just enormous potential to implement the actions in all 5 of the areas that Bob covered in his opening remarks, relating to payment, relating to access, relating to workforce, relating to information technology, and finally, with regard to accountability. You'll notice that there was not a star next to the action 5.3 under accountability. And that is because I'm pleased to announce that the fund, the Milbank Memorial Fund, will take up the challenge of coming up with a high quality primary care implementation scorecard. We will be producing that scorecard. We are, I would say, weeks away from announcing both our funding partners and our implementation partners, but we envision an annual report to measure the health of primary care. Bob outlined frankly, the fact that we're moving in the opposite direction. Primary care is fragile and weak at just the time when it could be of help. And in terms of helping to address the effects of the pandemic, to prevent the pandemic, to address decreases in lifespan, and increasing disparities. And so we improve what we measure. And so on behalf of the fund, I'm pleased to take up this challenge of a high quality primary care implementation scorecard. The other thing I want to speak to is my experience as a state official. I was a health insurance commissioner in Rhode Island, and what I see now in our work as a fund with state officials. There is leadership at the state level of our own primary care, but we need partnership and leadership at the federal level. And that's why I'm really pleased that we have a number of our partners from a number of different agencies in the federal government with us who've taken time on a Sunday afternoon to talk about this common goal. And so I'm sort of the setup for really, I think, these important discussions that will follow about the role of federal government. And what I'm going to do is hand it off at this point to Judy Steinberg. She is the senior advisor to the Assistant Secretary of Health. She's been heavily involved with these conversations. She has borne the brunt of Bob Phillips and his relentless advocacy around this work. You should know that you're well represented. And Judy, please take it. We're very anxious to hear how you've been working with the recommendations that the committee's come up with.
Okay, thank you very much, Chris, and thank you to the meeting organizers for inviting me to present on this panel today. It's a pleasure to be here, even if it is a Sunday. So I do have some slides. Let me just pull them up. There you go. That you should see them now? Yes? Good. Okay, so as you just heard, the National Academy of Medicine primary healthcare report calls on HHS to implement some very specific actions and also to take on this leadership role in overseeing and steering its recommended action plan. And I want you all to know that HHS and the Office of the Assistant Secretary for Health recognizes the importance of having a strong primary healthcare foundation in our healthcare system. And we are exploring actions that we can take to strengthen primary care to ensure high quality primary health care for all. So our work begins with our mission, and here is the mission of the Department of Health and Human Services. And I do want to emphasize that underlying this mission is an underlying principle, and that is health equity. Also on this slide, you can see the agencies that the National Academy of Medicine report called on for its specific actions in the implementation plan that was just reviewed. Now, just a word on the Office of the Assistant Secretary for Health. Our new Assistant Secretary for Health is Dr. Rachel Levine. She's a pediatrician and adolescent medicine specialist, and she gets primary care. And here on the slide, you can see the vision for the Office of the Assistant Secretary for Health and the role that we play in all that we do. So given our focus on health and our role in convening partners, both federal agency partners and external stakeholders, to organize and lead national initiatives, strengthening primary care and working in that realm is right up our alley. So that brings me to what is it that we're doing? So the initiative to strengthen primary health care was launched by the Office of the Assistant Secretary for Health in September. Its aim is to explore actions that HHS could take to strengthen primary health care in our nation, ensure high quality primary care for all, and improve health outcomes and advance health equity. And we have a specific activity. That is to develop an HHS plan to submit to the Secretary for review. It begins with delineating the HHS's role in steering, coordinating, and overseeing the implementation of the plan for strengthening primary care and how we would do that. And also the specific actions to be taken by HHS and across HHS agencies with deliverables and timelines. And the National Academy of Medicine Primary Care Report can inform the development of the HHS plan. So here's a status update. It's just been a month. I was asked to take on the lead for this initiative in the end of August, and we started in early September. We're working on staffing a team and also looking to receive additional support for the development of the HHS plan. We are working with our HHS agency partners, HRSA and ARC, who were sponsors of the National Academy of Medicine report, and meeting with their leadership on a regular basis for guidance and to keep them in the loop. We're also, as per our work plan, reaching out to federal agency partners to discuss specific actions, and also reaching out and speaking with external stakeholders to hear about the actions that they're suggesting. We have developed an HHS plan proposal framework, like an outline, and that's currently under review. And then importantly, I wanted to highlight for you that there's a lot of activity that's happening in HHS and in the current administration. And we're going to do a crosswalk of the National Academy of Medicine implementation action steps with some specific activities, such as the HHS strategic plan, which is under development right now, as well as some committees and councils that are developing action plans that are focused on behavioral health, social determinants of health, and health disparities, and also a plan that's coming underway around telehealth. So we're doing this to be efficient and avoid duplication of effort, also to align our efforts across these different plans, and importantly, to understand the actions that agencies have proposed or have already committed to that will essentially work towards strengthening primary care. Last, we aim to complete the HHS plan proposal by spring 2022. And with that, I'll close. Thank you all very much. Here's my contact information, and I look forward to our discussion. So now I'll turn the presentation over to Mr. Stephen Lopez, Counselor to the Secretary of HHS. Stephen?
Thank you, Dr. Steinberg. And hello, everyone. I just want to extend my thanks for inviting me to join today's panel and represent the immediate office of the Secretary of the Department of Health and Human Services. As Judith mentioned, the mission of HHS is to enhance the health and well-being of all Americans by providing effective health and human services and by fostering sound, sustained advances in the sciences underlying medicine, public health, and social service. Equity is an important priority for the Biden-Harris administration and is a key part of our mission at HHS. This includes addressing health disparities and promoting equity for underserved populations. And the Secretary has made it very clear that this is a key priority for him as Secretary of HHS. Underserved populations include individuals who belong to communities that have been denied consistent and systematic, fair, just, and impartial treatment, such as Black, Latino, Indigenous and Native persons, Asian Americans and Pacific Islanders and other people of color, LGBTQ+ persons, persons with disabilities, persons who live in rural areas, immigrants, and persons otherwise adversely affected by persistent poverty or inequality. Secretary Becerra aims to carry out President Biden's vision to build a healthy America, and his work will focus on ensuring that all Americans have health security and access to health care. And we understand that the root causes of health inequities are societal and structural inequities at multiple levels, including interpersonal, institutional, and systemic biases and policies and practices that favor some groups, but not others. Strengthening primary care provides a path to improving health outcomes and advancing health equity. And the data are clear. Better primary care is associated with more equitable distribution of health. Stronger primary care systems are generally associated with better population health outcomes, including lower mortality rates, higher infant birth weight, greater life expectancy, and higher satisfaction with the healthcare system. And a larger primary care workforce is associated with better health outcomes, including increased life expectancy and reduced cardiovascular, cancer, and respiratory mortality. So what actions are we taking at HHS? Well, the Biden-Harris administration recognizes the urgency and the need for action-driven efforts. And we are pleased to see that there is now a concerted focus on health equity and environmental justice across sectors, federal and state government, professional societies, and academia, among others. At the federal level, some of the work that we are doing to advance equity include the development of the HHS strategic plan that Judith referenced in her presentation, which will place equity at the center of our strategies. Designating an agency priority goal with a focus on equity that will hold us accountable to measure progress over the next 2 years on our equity work across the department. Convening the COVID-19 Health Equity Task Force and recommendations on how to address public health emergencies moving forward, and launching the Office of Climate Change and Health Equity and the Office of the Assistant Secretary for Health. And now this initiative to strengthen primary care in our nation, well described by Dr. Steinberg. Again, primary care is the foundation of our healthcare system, and we look forward to the recommendations in the report and identifying opportunities for HHS to move the ball forward. To achieve our aggressive goals, we must have a strong foundation of healthcare and primary care. So again, thank you for your time and for inviting me to participate in today's conversation. And now we'll pass the mic to Jim Macrae. Thank you.
Great. Thank you so much, Stephen. And thank you so much to the National Academies for the report, for convening today's session. I really do personally feel like we are at an inflection point with respect to primary care in this country. And I think your report is a key piece of it. But as you said, I think the key part of it is whether this will actually turn into action and meaningful change. What we've seen with the pandemic has really put a spotlight on the importance and, to be honest, some of the challenges that we have with primary healthcare in this country. And I think it's really a moment for all of us collectively, wherever we sit, to make that kind of impact. I myself have been overseeing the Community Health Center program for, I hate to say it, but almost 15 years at this point, and have seen just tremendous growth in the program itself, but also tremendous change. And because of all of that, it really does give me hope that primary care in this country, not just for the underserved, which I think is critical and a key piece of what we do in the health center program, but really across the board can make meaningful change. In our health center program, we have about 1,400 community health centers across this country that operate about 13,000 service delivery sites, providing care to about 29 million people. That's roughly about 1 in 11 in this country. Vast majority of those are living below 200% of the poverty level, over 90%. 2/3 are racial and ethnic minorities. They serve almost 1 million people experiencing homelessness, as well as almost 1 million migrant seasonal farm workers, as well as about 400,000 veterans. And really happy to see Kameron on the call today and the great partnership that we've had with the VA. What I really see, though, is sort of 3 key things going forward that I wanted to share related to the report. The first is about expanding access. And you see that commitment from the administration. First, through the American Rescue Plan, we invested almost $7.6 billion into the Community Health Center program to expand their capacity to do vaccines, care and treatment, as well as testing for COVID-19. And as Stephen said, that was really a focus on the whole issues of health equity and making sure that those most vulnerable in our country were reached. It also, though, included investments in primary care itself. And in particular, just recently, we invested in capital to actually support the infrastructure to support that kind of expansion. In addition, the president's 22 budget includes a commitment to double the overall investment in health centers on an ongoing basis, which is significant. That would be almost a $5 billion ongoing investment to expand the capacity. And really, it's 3 prongs to address that. One is to go into communities where there isn't currently available primary care, and there are a number of communities in this country, as the report pointed out, that don't have adequate access to primary health care. It's also expanding that footprint of what primary care actually looks like, and I was really appreciative of the report that you talked about not just medical care, but behavioral health, oral health, and all the enabling services that are critical to make sure that people get access to care. And then finally, one of the key other components of the whole effort to double the program is to truly address health equity and health disparities, implementing evidence-based practices, but involving the communities to address those social determinants of health. Another key part that we see from the report is investing in the primary care workforce. One of the reasons why we were a co-sponsor in this project, and Andrew and Bob know this, is that we were worried about primary care providers before the pandemic, issues of burnout and well-being. And COVID-19 has just put an enormous spotlight on that, and we continue to be very concerned about it. And we really see that concern and the effort to be addressing everything from training at the very beginning of primary care all the way through practice. So we know that getting people exposed to primary care, we know getting people exposed to underserved communities makes it much more likely that they're going to practice and be involved in primary health care. And if we don't do it, it's going to have a negative impact. We also know we need to make primary care more attractive. We need to create opportunities for reductions in overly burdensome paperwork. We need to create opportunities for them to engage more fully in the practice and training of future providers. We've seen that as a huge recruitment tool. In fact, almost 70% of our health centers are now involved in training. And we need to expand our efforts to bring joy back into primary care. So one of the things that we're actually doing is this year, we're going to be conducting a survey of all of our staff to set a baseline of where we are with our workforce and their satisfaction. But we have a lot to do in that space to really address our workforce. And then finally, the last piece of the report, which we're starting to work on with our colleagues in CMS, is really looking at payment. How do we move from really the orientation of paying for visits to that more comprehensive role that primary care can play, and making sure that the reimbursement follows that. When we've had our conversations, what we've said is, what do we want primary care to look like? And then let's figure out what a reimbursement structure that supports that would actually be. Because far too often the payment drives how care is delivered as opposed to the reverse. So I'm very excited to be a part of today's conversation and dialogue, very excited about the report, and a big thanks to the National Academies. At this time, I'd like to turn it over to Kameron Matthews to share perspectives from the VA. So thank you.
Thank you so much, Jim. And this is such an exciting discussion to be a part of. And I of course, have to acknowledge, as she's of course already spoken of, Dr. Carolyn Clancy here. I think from the VA's perspective, it is without a shadow of a doubt that we are not only aligned strategically, but I would even say operationally, as far as looking at the implementation of high quality primary care throughout our health system. Our very values are aligned. Of course, our delivery model, which many of you are aware of, really promotes the concept of usual sources of care that's both accessible and equitable. But of course, as you look even beyond that, with how we even purchase care outside of our system, we are indeed prioritizing the enrollment of our veterans in primary care systems and how that then integrates back into VA through care management models and the like. We promote, of course, that our primary care is both multidisciplinary and interdisciplinary, that we bridge multiple modalities of care, even state lines, with our really federal supremacy over telehealth work, and how we are able to look at that veteran care regardless of where they may be living, where they may be summering, but that indeed that the technology even is helping facilitate that communication. And I think it's also worth highlighting more than anything, this delivery model that we have. I'm assuming all of you have seen, I know Bob has forwarded it around in multiple circles, and we are very proud of the recent article that just was published this month in the Journal of General Internal Medicine regarding primary care through VA primary care teams having about 25% lower costs just through the sheer enrollment in primary care, and our ability to control costs in other modalities, even when comparing the same sort of patients through their own Medicare enrollment outside of the VA. I think we have to acknowledge that one of the strengths, of course, of the VA system is that we have the strength of our really national source of data that allows us to approach our interventions as equitably as possible, and to really even resist the one-size-fits-all mentality. We tend to think of veterans as, or at least we're trying to step away from this, but I think traditionally we tend to think of veterans as a single unit, but that instead we really are seeking through our data to differentiate our patient populations, to look at tailored responses that acknowledge primary care, even down to our women veterans, our homeless veterans, our geriatric PAC teams, as we even have it, really do supply different scopes of care and acknowledge the larger concepts of what I guess, is parallel to really community-based care, but really differentiating the needs of the individual veterans and what they're receiving in primary care. And again, stepping away from the one-size-fits-all concept. We are equally as interested as I'm so happy to hear the conversations from our HHS colleagues. We are equally as interested in being in the federal conversation. Of course, our partnership, our interoperability, and even our operational integration, I'll differentiate with our partners in the Public Health Commission Corps, as well as DoD, really does lend itself with our ability to continue to influence and continue to advocate for that stronger primary care infrastructure. Although we may have different approaches to our delivery with regard to DoD's mission, with regard to military readiness, and of course ours more to a different sort. We of course have the ability to really emphasize that partnership and to look beyond, obviously, payment incentives, but really how to best coordinate that care, especially when you're looking at our veterans that are dual eligible. And we could even look at that broader population of the triple eligible, those who are indeed also enrolled in Medicare. But it even goes beyond that. Jim, I'm so glad you're acknowledging really the connection. VA and health centers, a significant portion of veterans are enrolled in individual vet centers, are still receiving services in the VA. The ability for us to bridge these multiple different programs and to use this as a model. It is not just about veteran care, but why are we not also making those connections of other patient populations between multiple federal services? I think it would behoove us, again, to look at VA as a model, and we are ready and willing and able to serve in that role. Of course, our ability to be a part of this larger, not just academic conversation, but operationally how we can move forward with influencing these changes across our nation. Really, we can be at the lead of that. Of course, with Dr. Clancy's leadership, how can we not acknowledge the strength of our research program, of our training programs, and the emphasis that we place on training our staff in the communities where their patients are being served, meaning that many of our staff are veterans themselves. They have the experiences of the veterans themselves. That exact parallel, obviously, should be applied to the communities that we are concerned about when we're discussing inequities and we're discussing poor primary care infrastructure as a whole. What we've stood up as far as the VA can be directly applicable to other communities when you're thinking about building of resources, and we are happy to be a part of that conversation. So with that, I think I'll just end. Many of you are aware of our upcoming, current deployment as far as kind of the digital health concept that we are taking part in, and again, also hoping to lead the nation in our modernization effort as we move to our Cerner deployment along with DoD. I think there is plenty of room for us as well to be a part of that conversation and how we can really hold, I think, our partners in the IT space more accountable when it comes to primary care, and how their tools are actually assisting us in achieving a lot of the goals of the committee. And we stand ready to serve in that advocacy space, as clearly being the largest deployment that any EHR product has ever seen. I think we'll have the ability to really stand by everyone's side here to see that we're achieving those goals as were outlined by that specific objective. So with that, thank you very much for including VA in this conversation. We are eager and willing and at the ready to continue to move forward with these objectives. And I'll hand it over to Dr. Maya Pham. Thank you.
Thanks very much, Kameron, and thank you for having me here today. It's wonderful to be back in the tribe of primary care, which is not a pleasure I've always had the past decade. But also to help move the conversation along a little bit. I know that we've spent now some amount of time talking about the vision for primary care and its challenges. We also have to talk about action and what it takes to help fix the problem. And so it's my job to touch a little bit on the recommendations from the NASM report on financing and payment for primary care, but more so to share with you a vision for how we can move forward on that. So as someone has said, we would like we would like payment to follow the outcomes that we want to achieve rather than dictating outcomes we happen to dangle incentives for. However, I think that within this circle of friends, it's really important to grapple with the reality that I honestly don't think, as a matter of practicality, we can go forward and advocate for better financing and payment for primary care on the basis of saving the workforce, or a kind of Me Tooism that primary care is just a good and end in and of itself. We don't live in that political world right now, unfortunately. And so I would posit to you that it would be more effective for us to reframe the conversation as for policymakers who have stated deliberate goals of reducing inequities, of improving rural health, of generating whole person and community health, and of finding value in our healthcare system, that none of those goals are achievable without a sound primary care infrastructure. So that we change the conversation, that it is not about giving primary care providers their due. It is about achieving the results you're trying to get to anyway, but you have to go through a solid primary care infrastructure to get there. So under that framing, the NASEM report, I think, touched on many recommendations where there's strong policy consensus around the need to invest net new funds into primary care, because it is an infrastructure that has been starved for such a long time. That net new investment should take into account what modern primary care could and should look like, including, for example, the appropriate financing and payment mechanisms for telehealth and other modes of care delivery that could broaden access and help reduce disparities, while at the same time moving the system to higher value. That doing so, in all likelihood, must require moving away from fee-for-service. And the NASEM report, I think, wisely recommended that we begin with a hybrid approach to try to find that balance between fee-for-service in order to ensure productivity, but also a population-based payment that gives primary care clinicians and practices the flexibility to do what they need to do for that patient in front of them, as well as to invest in infrastructure that can sustain their enterprise and make them much more able to actually execute on population health. Once again, premised on significant net new investment. There is a group of us advising some primary care advocates. We estimate a very minimum bare floor of 25% increase. And we think that's extremely conservative and low, and it probably needs to be closer to double that in terms of net new investment. And then to do that, keeping in mind that this is not a redux of the 1990s primary care capitation. We are not interested in insurance risk for primary care clinicians. We're interested in performance risk, because that's something they can handle. And until you have re-engineered the overall delivery system in such a way that primary care providers can actually move market levers and influence other providers, they have no business taking insurance risk. So it's performance risk, it's population-based payments, hybrid with fee-for-service, although full performance capitation for anyone who wants it, with appropriate risk adjustment, which implies to us new risk adjustment tools that are specific to primary care, because hospital utilization may not at all predict what is necessary in a primary care setting under current risk adjustment rubrics, and with quality metrics that reflect the outcomes we're after, as opposed to checkboxes that are easy to measure. And having said all that, what does the practical path look like going forward? I am stateless I am nationless as a primary care advocate right now, although my organization advocates on behalf of people with IDD. So it is not for me to say what the political strategy should be, but I will tell you that it will have to be political. And I will tell you that many primary friends of primary care won't want to take up that banner unless primary care fights for itself. That said, I do believe this will require a much broader coalition, non-traditional coalitions. I don't mean just payers and professional societies. I mean other primary care professions. I mean consumer organizations that have a stake in this. I mean investors who have a stake in primary care doing well. There's a lot of money flowing, capital funds flowing into primary care right now, and they're going to want their investments to succeed. We need to think broadly about the coalition that can make the case to policymakers. Who are those policymakers? I think that the NASEM report made a cogent argument for Medicare being that critical linchpin, the leader among payers that can really shift the whole system, because the Medicare fee schedule and Medicare payment policies are so critical as the backbone for how other payers design their systems. That said, it is an entire federal government, Judy, with many levers at its disposal. It is not just Medicare. It is also FEHBP. It is also the ACA exchanges and the plans there. It is also Medicare Advantage plans and TRICARE. And so there's, we talk about multi-payer engagement, but we have a lot of multi-payer within just federal government that can be leveraged as well. I want to acknowledge that this is hard, and this is we are below 50% probability for this being a successful campaign. That's and nothing about recovering from a pandemic or a recession helps this effort, except that this is a sector in the delivery system that lost $15 billion last year. That's a conservative estimate. And the country cannot recover from COVID without helping primary care recover as well. So want to acknowledge that the Primary Care Collaborative is really trying to take a leadership role in this regard and hewing closely to the NASEM recommendations. Please keep your ear out, your personal and professional ears out for how organizations you're affiliated with may become a part of this coalition. There is some really concrete analytic work that needs to be done in order to feed policymakers the nuts and bolts of how to do this. I'm happy to share more with you offline about that, but some of that work will be funded. I think we can say publicly now by the Commonwealth Foundation, the Commonwealth Fund, and another foundation that I'm probably not allowed to say yet. And so there is, I think, broad support from the intelligentsia. We need to make this real and feel real to policymakers who worry about their communities and their constituents and what it means economically and in terms of life outcomes. If we can make that real to them and not about saving a burned out workforce, as deserving as I feel that is, then I think we might stand a chance. And with that, I'll turn it over to Kevin.
Thanks, Mai. All right, you set us up for a challenge here, so this is great. It is a treat and an honor and a little bit intimidating to wrap up this panel of illustrious speakers. And I do want to say it's wonderful to see so many friends and colleagues in attendance. So hello to you all. So, all right, well, let me go back and start with a positive. And then I'm going to challenge us to redouble our efforts to tackle the root causes of the primary care predicament in the United States, picking up, I think, on some of the themes and kind of encouragements that Mai just put forward to us. So, I mean, the first thing I want to say, it is really a terrific National Academy of Sciences and Engineering and Medicine report. So I really want to thank everybody on the committee, because I think it was an unusual report in several respects. And there's two things I really want to hit home from what Bob gave in his overview. The first is the committee coming right out and saying that primary care is a common good. Now, that may seem self-evident to all of you here in attendance today who understand primary care and care about it. But I mean, let's face it, in the United States context of a very market-oriented health system environment still, that was a profound and I would say a bit edgy statement to come out and just declare that primary care is a common good, and to try to move us away from thinking about judging primary care in terms of short-term return on investment. And that's really true, has been true in my experience, not just from private payers, but from government payers, which is idea, show me within 12 months your patient-centered medical home intervention will yield some short-term return on investment with lower hospitalization. So it's really helped us to move out of that framework and think much more broadly of long-term benefits to society of primary care. The second was really emphasizing an action-oriented implementation strategy plan, which was really terrific. So for the panelists today, I mean, I hope you all feel as like positive I do to have these great people coming together from different sectors, from foundations, from health agencies in the federal government, from professional organizations who also clearly are committed to advancing primary care in this country. It's, to see Chris Colwell talk about, Milbank Fund is in this for the long term. It's not just ending with funding the report, but they have skin in the game to try to move the scorecard forward. I believe the Samueli Foundation that also contributed to the report is also planning to have some continued investment on the implementation aspect. So that is terrific to have some of the funders here say, we still are going to continue to help move this work forward. Second, I mean, today, have it heard here, this is really in many ways among the first public announcements of this new federal initiative to strengthen primary health care. So I'm really grateful to Dr. Steinberg and Stephen Lopez for sharing the outline of what I think is really an effort to take the committee and report's recommendation for a high-level primary care council and the Department of Health and Human Services and really to manifest that in this new initiative. So I think we're really excited to see that moving forward. Having people like Jim Macrae and Dr. Kameron Matthews talk about, man, they are so all in understanding for, community health centers in this country, rural health centers, for the VA system. Primary care is just critical to what they're doing and that they are committed to this. And then to have some of the new evidence from the VA that, Kameron cited is terrific. So I think this is all positive. So I think the real question is one that Jim put to us. Jim, I believe I heard you say, the question is, will the report translate into action and meaningful change? And I have to say, having been at this for a long time, like many of you, I always have to think, why are things the way they are in the United States and in our nation's health system? And what will it take to change the state of affairs so that the disadvantaged primary care sector can really be revitalized in service to the needs of our nation? And, it's always great to have our international colleagues on these meetings because you can just sense the incredulity, right, of Jan de Meissner sitting there. And I know, Carmen Garcia Pena and Carol Herbert, Martin Rowland, I'm looking, because I can read their body language even on Zoom, is saying, like, what is up with you folks in the United States? How do you spend 40% more than any of our nations on health and have a life expectancy on average that is 3.5 years younger, less than what we have in our nations? What's up with you all? And I also saw Rosemary Stevens participating, and Rosemary is a great historian in health and medicine. And again, you have to understand history to understand where we are today. And I think we do have to look at a historical perspective. And why has there been such stubborn lack of progress, frankly, in so many of the things we care about to make primary care work in this country? So 40 years ago, Paul Starr published the book, The Social Transformation of American Medicine, really a classic. And the first sentence of that book reads, "The dream of reason did not take power into account." So I'm thinking a lot these days about the persistence of structural problems that threaten the health of our people and our planet, such as the issues of climate change and equity that are the themes of this year's National Academy of Medicine meeting. I mean, despite the clear evidence about what needs to be done to rectify these problems, and it seems to me that it comes down to Starr's observation that what is reasonable to do often conflicts with the interests of those in power. You know, let's face it, folks, we cannot monetize primary care. A whole way of delivering care based on relationships, not on commodification of health. Primary care, as the committee declared, is a common good. It's not a profit center. You know, and I think we always have to come back. There are fundamental differences when talking about the United States compared to our compatriots in other nations that all have some universal health program with a strong role for government planning, if not actual government financing and administration. So I think then I would close by saying the challenge to our interest group and to all those committed to strengthening primary care in service to the people of our nation is to speak truth to power. You know, to go back to Paul Starr's comment and to call out what Daniel Dawes at Morehouse refers to as the political determinants of health. And I think as part of that, I would take Mai's comment to heart about maybe we just need to think a little bit about our own complicity in maintaining the status quo. You know, do we too often advocate in a way that seems self-serving? Do we talk about primary care spend that it seems like, how do we, you know, make doctors earn more money? Have we been so much in our kind of, sectors of physicians and nursing and divided and conquered and seem ultimately a lot of the work we've been doing comes across to the public as self-serving. So how do we take up Mai's challenge to form a broader movement in partnership with the public and with patients, with consumers, with advocacy groups like my Pham is working with advocacy groups around people with disabilities. How do we link arms and really have a much broader coalition that can march forward together to make primary care a policy and political priority in this country that will become sufficiently resourced and organized to achieve its promise as a common good. So I would say, I think this NASM report is a terrific step. I mean, and to see, Judith and Stephen here today and say, yes, we will see some action at the federal level to really create some of this organizing structure, to see leaders of agencies, foundations committed, wanting to move this forward. So let's absolutely keep pushing that. But I think then what's beyond that? I mean, what would we really have to do fundamentally to shake up the kind of dynamics in this country that seem to always hold us back from really getting primary care where it needs to be in a more reasoned approach to healthcare delivery in this nation. So with that, let me close and turn it back to Andrew, I think.
On to Mary.
Close enough, Dr. Grumbach. First of all, many thanks. First to you, Bob, for setting up the conversation, talking about some of the details of really important action steps that were advocated in the report. It's really such a dynamic report with a lot of expectation, much of which was just talked about across our various panelists. And special thanks to each of the panelists too, of course, for sharing the insights that you've shared. And Kevin, as always, your synthesis, in addition to adding in your seasoned expertise and perspectives, really value add for the conversation. We have some important observations that have been shared in the chat. And not always so much as questions, sometimes as observations listed there. I do think it's important for us to bring some lift to some of them. And Andrew's going to help me do that because it's there's been a lot of chatter there. But before I do, and Andrew, if it's okay with you as a co-chair, I'd like to go back to the panelists one more time. They have now heard each other speak on this topic with this particular agenda for the first time, hearing each other. We've got people from Pham foundations, federal sector, private sector, et cetera, on the panel. And I would just like to give them a chance very quickly, if any of them would like to react to what somebody else has said or add to their own remarks, and then immediately from following that, pick up on some of the observations and questions that have been raised in the chat. So before I do that, is there a burning observation, an addendum that one of you on the panel, or you too, Bob Phillips, for that matter, I would care to add in before we get to some of the comments in the chat? And as an aside, I'm not going to assume that everything that's been added in the chat is being seen, especially by our outside the Academy participants. So I'm not going to assume that they've seen that, and that's the reason why we'll bring in some of those comments. But first to the panelists and to Bob, anything that you heard you want to react to or add to the conversation thus far? It's been so rich.
Mary, this is Bob. I would just add very quickly that there's a lot in this report, and there are a number of comments that have come up in the chat that are so helpful because they've let me point to some other things in the report that we've not had a chance to talk about today. But the integration of behavioral health is a priority lifted by the report. And as an example of integrating more team-based functions into primary care, there's a lot in the report about dealing with social determinants of health and at the community level, not just the patient level, and getting back to community-oriented primary care models of care. So I would invite folks to take a little bit deeper dive into the report. It's very searchable for particular ideas, but with the notion that there might be things here that are closer to your heart that might be something you'd see a path to championing. Because we need a lot of the folks in this interest group to pick up pieces and to join some of the collaborations discussed today to make sure that this report doesn't fall flat. Thanks.
Thanks, Bob. And then I'm going to go to Judy, then Jim, then Chris. Judy?
Thank you. And thank you all. It was really, I mean, I've been taking my notes as well, as I'm sure as others have as well. But I really would like to reinforce some comments that were made about the importance of working actually cross-government, not just in HHS. Kameron, I want to let you know that the VA is right on top of my list of agencies to reach out to, and also I think there's much to be learned through the Department of Defense. The White House has some offices that are applicable in terms of for example, the Office of Science, Technology, and Policy as it relates to telehealth and connected health. So I've already made some connections with them, and I want to assure you that that kind of approach is what we're taking in developing this plan for HHS.
Thanks, Judy. Jim?
I think the two pieces that really struck me, and I really appreciate the feedback from my other panelists, one was the focus on primary care being a common good. And what does that actually mean? And I think that was in the chat, like how do you actually operationalize that? Because we have such a mentality around payment. And then the other comment at the same time saying we have less than a 50% chance of being successful because of all of the current forces in the system and how things are set up and how we even talk about primary healthcare and what it does, and almost reconciling those two realities. And the other piece, honestly, for me, Mary, is, and this is my appreciation for you, is it takes leadership within the organization and real commitment. And I know when Mary was running HRSA, one of the things she continually did with us was really push us to think differently about how we do our work. And you need that in a bureaucracy. But the other part of the equation is you need outside forces also pushing on the same way if you're really going to do anything different. And it's really combining those two different pieces in terms of making real change. And it's going to be incremental. I mean, it may be in fits and starts, but that's the other thing that I've seen overall. But I think for me, it's that reconciliation between common good and the payers, and how do you sort of reconcile those two pieces in terms of how healthcare is organized in this country.
Yeah, thanks for those comments, Jim. And Chris, your hand is up.
Thank you, Mary. I just want to underscore some comments that Mai and Kevin made, and it really it's a good baton pass from what Jim just said. I think we've won the argument about primary care from a logic standpoint. Kevin, I never heard that. I'm embarrassed to say I'd never heard that Paul Starr quote. It's wonderful. But it is up to us to make it easier for our federal partners to do what they know to be the right thing. And that means almost, Bob, I wish we could have come up with a science of coalition building, because that's really what we need for our implementation plan. It's looking for partners that prioritize primary care, so it's easier for the federal officials, our federal partners, to act on what they know to be true. We have a real opportunity now because the Biden-Harris administration has framed this as equity. And as Mai noted, the road to equity, to health equity, goes through primary care. I see Neil Kalman on the call. Jim knows this. You cannot get to equity without talking about primary care. We have to get other people engaged in that discussion so that our federal partners can do this work that we're urging them to do.
Thanks, Chris. Mai, I'm going to go straight to you.
Thanks, Mary. I appreciate all the comments, and I appreciate the for me internally, it's very important to hang on to that framing of healthcare is a common good. However, I don't have such high regard, frankly, for many political leaders on either side of the aisle. I think for them, it's very pragmatic decision making. And so I approach it a little bit more in a mode of parenting, if you will. I'm gonna hope for some internal motivation on their part in the framing of common good, but I'm not gonna rely on it. And so I don't mind using some, some somewhat scary counterfactuals to help motivate them, right? But it's also important to make concrete what it means for primary care to be a tool to the ends that they care about. So we can say it's important for equity. We have to spell it out for them. We say it's important to equity because populations that have many social challenges, environmental challenges, need clinicians who have the flexibility to spend more time with them in order to connect with the community-based organizations and support services without having to worry about the lack of a billing code for that activity. You have to really spell it out for them and make it visceral for them, because they have constituents, right, who right now, practically anyone with an elderly population in their congressional district, which is everybody, is concerned about COVID. Elderly people, those who are vulnerable to infection, are the last people you want to bring into the office if you don't have to. You want to fund telehealth. There's no way that the Congressional Budget Office or OMB or even CMS will allow you to offer payment parity for telehealth on a fee-for-service basis. Get over it. Here's the path. Let us offer you a path to solving that problem. It is paying primary care, population-based payments at an elevated price so that they can afford to deliver the telehealth to save your constituents. These are just, I'm not a communications expert, but I am cynical enough about our political leadership that I know this group can be creative enough with your argumentation in order to get the points across in a visceral way.
Thanks, Mai, for those comments too. And both the last comment, Mai, the comments you were just making, as well as some of the others that preceded you, actually speak to some of the observations that were raised in the chat. One of them, for example, being, how do we distinguish this report from prior reports? How will this report be executed on, operationalized fully, robustly, compared perhaps to earlier or other reports released by the National Academy of Medicine? And you just talked about, just because you're the last person who was speaking, talked about what you think needs to happen and how it needs to happen differently in terms of really fully moving this agenda forward. So that's just one example. Bob Phillips, you talked about, for example, the report speaking to behavioral health. You mentioned that in passing, and there was a comment comment in the chat asking whether or not primary care includes oral health. So very specific question, but I don't want to minimize any question or observations. So Bob, since you talked about behavioral health, would you mind just coming in on that, whether or not oral health is part of the primary care rubric as well?
No, thanks, Mary. And it was really helpful to have a dentist and folks who work in health centers with dental access. It was very important. I talked about behavioral health because the evidence for it is so strong, and the evidence about the lack of payment systems to support it is equally strong. Oral health is also really important, particularly in communities where people have poor access to oral health. And there are really good models, particularly as Jim mentioned, in fairly qualified health centers for integrating oral health so that people can get all of the care that they need in one place. The report talks about the value of doing that more broadly, integrating oral health into primary care, and where it's not possible, where your practices are small and being able to invest in that kind of infrastructure is not possible. There are good models like Vermont's, where there are community-based resources where multiple practices can refer patients because they have relationships for mental health, for oral health, for social work. So it's not one model, but the capacity to have those relationships where you're handing off a patient who has a particular need, including oral health, is just so important.
Yeah, thanks, Bob, for answering the specific and then also putting it in that larger context of other services needed. There was a lot of conversation that I think was catalyzed by Dr. Clancy's observation that DOD has equities in this space, VA does as well. And I think Judy answered that really nicely in terms of calling out the intention to link with other federal agencies, not just operating divisions of HHS, but also more broadly. So I don't know that we need to spend more time on that other than just to reinforce it, that there's clearly, Carolyn raised the issue, many, others came in behind it being incredibly important. And that does get at the issues needing to be less siloed, more cross-cutting in terms of activity in this space. So I don't think more needs to be said about that. Andrew, I just want to turn to you for a second and see if there's anything from the chat. I have others, but I'm also sensitive to time. I know I'm a little bit over time, but Andrew Bazemore, is there anything you want to tee up from the chat? And then I can transition us, I will, onto the next part of our meeting. Andrew?
Mary, there's more than we can possibly get to in the time. I think the only one I might tee up there's a note that the report is specifically calling for adjustments of payments for social risk so that primary care clinicians and teams specifically that are taking care of disadvantaged populations actually have the resource and tools they need to address not only clinical care, I'm ad-libbing a little bit here, but also those social needs specifically. And I just wondered if Stephen Lopez had any insights or comments on the linkage that this is calling out between primary care payment reform and equity.
Thank you for the question. I'll try to be brief. I did want to just, before I respond to that, I just wanted to go back to Mai's comment and just lift that up again. She said it much more eloquently than I did about the road to making progress on health equity. No question includes primary care. So I just wanted to reinforce that once again. I think to what Mary just said right before this, there are a number of equities here, right? And the number of stakeholders internally at HHS that need to be a part of this conversation. So I think I don't want to speak for my CMS colleagues who are deeper into the weeds in this, but certainly I think there is a case to be made to your point, Andrew, about that point. I think having listened to this panel, I just have an even greater appreciation, I think, for just the multiple threads that need to be woven together in order to get this ball moving forward. But I certainly appreciate the question.
Thanks, Stephen. And let me just say thank you to all of our panelists and to Bob for your remarks and for sharing this wealth of expertise that runs through and across all of you. What an incredibly interesting conversation. I also want to thank the members of the public who have joined us for this part of the meeting, because at this point they will be disconnecting, and we're going to turn our attention to the last part of our meeting, which is going to be facilitated by Dr. Bazemore, specifically with members of the National Academy. For that part of our conversation, the panelists are absolutely invited and encouraged to stay with us if and as they can. But as I said, for the members of the public who've joined us, thanks much for giving us your time, and hopefully this was a helpful conversation for all of you. With